Hi, everyone. Today we're going to be discussing the management of acute rotator cuff tears in the young population. So in general, the acute rotator cuff tear is seen and approached as a completely different entity as the attritional chronic cuff tear, which is covered in a separate podcast. The acute tear is defined as a tear that occurs in a previously healthy cuff. In general, this would present as a patient with a previously pain-free shoulder who sustained a traumatic event, which is followed by painful symptoms. It is difficult to distinguish between a true acute tear versus an acute extension of a chronic tear versus an acute symptomatic episode in the setting of a chronic tear. The average age of patients in the traumatic cuff tear population is typically younger than that of the chronic tear population. The most common mechanism of injury is typically from a fall onto an outstretched arm. And importantly, early surgery might be indicated for these patients in an effort to preserve tissue quality, minimize tendon retraction, and therefore maximize healing and ultimate outcomes. With regards to the differences between traumatic and atraumatic rotator cuff tears, Mal et al. Performed a systematic review in 2013, primarily looking at traumatic tears. They identified a mean age of about 55 in the traumatic cohort, which was about 10 years younger than some of the reported averages in the atraumatic group. The most common mechanism of injury in the traumatic group was a fall into an outstretched arm, followed by an episode of forceful external rotation versus the more attritional sort of progressive development of the atraumatic tear. Accordingly, traumatic tears have a increased rate of subscapularis tears. In their population, they identified 80% of patients with reported subscap tear and about 40% of patients with large to massive tear in the traumatic group. And in terms of improving range of motion with surgery, the traumatic group appreciated improvement from 80 degrees pre-op forward elevation to about 150 degrees post-operatively. In terms of healing factors in acute traumatic tears, typically a more favorable healing milieu versus, for example, a chronic rotator cuff tear. In general, these patients are younger with improved healing potential. The tendon has undergone less retraction, especially in the acute setting, as well as less atrophy, which in general would manifest as a lower Goutallier score. And then furthermore, in the acute setting, these patients have an inflammatory response after injury, which may be unfavorable for symptoms, but can be favorable for promoting a healing environment and a healing response. Some important factors to consider when assessing acute rotator cuff injuries or any rotator cuff tear include the extension of the tear, the topography in both the sagittal and coronal planes. This would involve assessing the number of tendons involved, as well as the degree of tendon retraction, and then lastly the tendon quality as well, which we previously mentioned is typically pretty good in the acute tear. In terms of other injuries as well, it's important in the acute setting to assess and make sure you're not missing any other injuries. Biceps pathology is common, especially in the setting of a subscapularis tear, as seen in the image on the right, with medialization of the long head of the biceps tendon with the full thickness subscap tear, and then also other injuries like a glenohumeral joint dislocation or fracture, which may be associated with acute rotator cuff tear. In terms of timing, the cuff repair, there isn't any robust evidence to make any recommendations to approach these patients. There is a few studies out there looking at repair in the acute setting versus the chronic setting, see how patients are doing. This first one by Latine Mackey et al. Is just a case series looking at patients with acute traumatic tears. The patients had surgery within 3 weeks, which is very fast. Overall, there was a 96% satisfaction rate with these patients, 85% rate of return to normal strength, return of forward elevation, and 85% resolution in pain. And then Hantes et al. Performed a retrospective cohort study, again looking at early defined as less than 3 weeks versus late defined as greater than 3 weeks. Repair for an acute traumatic rotator cuff tear. They assessed constant UCLA shoulder scores. Patient mean age was 55, and follow-up was between 34 and 38 weeks. And they identified a significant increase in post-op constant and UCLA scores in the early repair cohort. After discussing this a little bit with Dr. LeBlanc and just kind of what we've seen here in Calgary, 3 weeks is perhaps a little bit ambitious for getting patients with acute rotator cuff tears to the OR. In general, patients may be offered at least a short-term trial of non-operative therapy, and if the decision is made to go in proceed with rotator cuff repair, typically would occur within around the first 4 months after injury. In terms of some of the more technical aspects of rotator cuff repair, there's a JOS review written by Burkhart and Lowe discussing arthroscopic rotator cuff repair. They discuss some important principles such as with modern suture anchors. The failure is actually more likely to occur with suture cutting through the tendon as opposed to the suture breaking itself. In terms of ways to prevent this from occurring, double-loaded or triple-loaded sutures can increase the number of fixation points of the suture to the tendon and therefore reduce the load. For example, doubling the number of fixation points reduces the load on each suture by about 50%. And furthermore, some of the more technical aspects of where you're putting your suture, there's something known as the dead man angle, which is the angle that the suture makes perpendicular to the anchor. This angle should be less than 45 degrees. And the tension reduction angle, seen there as theta 2 on the right, should also be less than 45 degrees. With regards to the type of anchor, metal anchors have been found in biomechanical studies to demonstrate more suture abrasion at the eyelet than biodegradable suture anchors. And then lastly, some principles of knot optimization, which include the idea of knot security, which is the effectiveness of a knot at reducing slippage when a load is applied, such as friction or internal interference and slack between throws, versus loop security, which is the ability to maintain a tight suture loop around a tissue as the knot is tied. So, for example, in the picture in A, there is a tight suture loop holding the tendon to the bone, but in B, there is inadequate tensioning due to poor loop security, so a loose loop, regardless of adequate knot security. With regards to single versus double row repair, the images on the right there, you can see in the top as a demonstration of a single row repair using triple loaded sutures, and the image on the bottom representing double row repair. There has been a demonstration of biomechanical advantage of double row repair, including increase in cyclic strength, tendon to bone contact, as well as footprint compression, as well as improvement in radiologic or radiographic outcomes in double row repair, including a reduction in re-tear rates in double row versus single row traditional repairs. But importantly, there's been no demonstration of any significant clinical difference between these two. In some of the subgroup analyses, there's some demonstration that double row may result in improved outcomes for tears greater than 3 centimeters, and perhaps double row repair in the acute setting may be optimal and achievable. This table is from a 2014 JBJS Reviews article. These authors reviewed the evidence, and their interpretation was to suggest using a double row repair in the setting of medium to large size tears, meaning 3 to 5 centimeters in tear size. And lastly, just regards to some considerations for repair of subscapularis. The working space for performing a subscap repair is confined, so typically would be performed first before swelling accumulates. And then also to make sure the biceps tendon is thoroughly assessed. And then the discussion of tenotomy versus tenodesis is for a different podcast. In terms of identifying the stump, more so in the setting of chronic tears, the subscap insertion can be viewed through the posterior portal with positioning the arm and some internal rotation. The torn subscap stump can scar the deltoid fascia, which makes it hard to identify. So when the subscap is torn off the lesser tuberosity, the superior glenohumeral ligament, coracohumeral ligament complex is also torn, with a portion remaining to the superior lateral corner of the subscap. So the comma sign, which is described by Dr. Lowe and Burkhart, is an arc formed by a portion of the superior glenohumeral ligament, coracohumeral ligament complex, and is a useful marker for the superior lateral corner of the torn subscap tendon. So that's demonstrated by the asterisk there on the right, with the dotted lines demonstrating that superior lateral corner of the torn subscap. Thanks for listening.